All right, so hello everyone. My name is Emma Banyard, and I'm a Master of Public Health candidate. I completed my practicum with Interior Health and supported their team to reimagine their approach to competency-based practice. I'd like to start by sending my deepest gratitude to some important people who helped make this a reality. First off is Jody, who really was my better half throughout this experience, and Annetta, who is my esteemed practicum supervisor. Additional gratitude goes to my wonderful UVic practicum supervisor, Dr. Kathy Worthington, for her great guidance and continued support. A big thanks also goes out to my work team, who so graciously supported me in balancing this workplace practicum with my regular work. And of course, last but not least, my friends and family who offered endless support along the way. To continue on in a good way, I'd like to acknowledge the Indigenous territories my practicum organization is situated in, as well as my own. So IH would like to recognize and acknowledge the traditional, ancestral, and unceded territories of the Dakal Dene, Tanaha, Inklakatma, Shwepmet, Statlium, Silks, and Chilcotin nations, where we live, learn, collaborate, and work together. I'm personally situated within the Silks territory today in what is colonially known as Kelowna, where I live, work, and play. The core of my practicum revolved around redeveloping the IH competency-based practice framework. This came with two key deliverables, updating the framework itself, but also redesigning the competency-based model as a whole. Overall, we hoped this work would support clinicians to assess and understand their own practice, for leaders and educators to support safe and effective and person and family-centered care, and to generally enable lifelong learning for high-quality care. So today I will walk you through the processes and work I engaged with throughout my practicum. To ground this work, it's important to understand competencies and competence. Typically, competencies are understood as skills, knowledge, and abilities to deliver safe, ethical, and effective care. But I'll explore later that this is more complicated than it may seem. Helping health professionals and leaders to develop and maintain competencies and competence fosters the ability to provide that effective, ethical, and safe care to the population. It also establishes a means to integrate best and wise practice and strengthen our health workforce overall. The province's health and human resource strategy highlights the need to address the ongoing challenges the province is facing with its growing and aging population and its increasingly complex health and social needs. This strategy sets the stage to ensure the people who care for our population are well supported to do so. The model and framework support the specific HHR focus on redesign and training, including actions on professional development as well as scope optimization. And IH, as one of the province's 5 health authorities providing healthcare services, employs approximately 28,000 clinical staff across an area of 215,000 kilometers squared, which makes this work pivotal in supporting a competent and mobile workforce within this vast region. Throughout this project, I aim to take an evidence-informed approach where I integrated best and wise practices. Engaging in a literature review and environmental scan was the logical place to start to ensure that I understood the landscape. The literature review primarily tackled understanding best practices in content and development of competency-based practice resources, and the environmental scan sifted through IH material and material from other health authorities and Canadian organizations. An evidence-informed approach that integrated these two elements allowed me to prepare for more transformative change. The literature was where I started, and it really highlighted a lack of standardization. It also pointed to an interesting theme where quite a few key sources indicated a misunderstanding of key language, such as the difference between competence and competency, which was suggested to be pivotal to both development of these tools and their use. Another key finding was the binary approach, which is either met or not met competence, or a more developmental approach, supported and demonstrated more by overall role performance. And this was suggested as another important decision to make. The binary approach, or those that focused more on competence as an ability to perform a task, were better supported by things like skills checklists rather than comprehensive competency frameworks. The recommendations to build competency-based practice pointed to the development of tools that support the clinician beyond simply skill and knowledge acquisition and focused more on the overall development as a clinician. It was not missed, however, that the more practical aspects of competence or the ability to perform a task were just as important. The environmental scan revealed themes aligned with the literature in that within IH and external to IH, there was lacking consistency in development, identified purpose, and use of the competency tools, including the way competency or competence was measured. Within the IH resources, I identified approximately 60 competency-based practice frameworks that were unique. Even among the other BC health authorities, there were inconsistency in approach, and rarely were they similar in appearance or use. This continued to allow me to strongly advocate for a shared understanding and standardized approach to competency-based practice within IH, and it also provided some explanation for the vast variability in IH, because it seemed everywhere else could also not align on how this should be done. Now, considering the literature and the IH context identified in the environmental scan, these foundational inputs were rounded off by collaboration with key contributors with the Interior Health Clinical Education team. This primarily included the regional educator for competency-based practice and clinical orientation and the clinical education leadership team. Their knowledge of current state, as well as the vision for the clinical education team via their clinical education strategy and its priorities, was helpful in applying the key findings to reality. So, bringing it back to the project deliverables, my process sought to update the framework and model it describes to align with those best and wise practices while balancing the operational and day-to-day need of the clinician and clinical leaders. I applied a socio-ecological framework to support the interconnectedness of the key invested partners and potential actions identified in the work up until this point. The socio-ecological approach was selected to acknowledge that interconnectedness of the influences on competency-based practice, ranging from individual clinician behaviors to broader organizational structures and policies. I employed the process described by Grant and Asanlo, which uses the analogy of building a house using a blueprint to support understanding, selecting, and applying a theoretical framework. And this framework served as my foundation from which to build. You can see in this visual that this supported identifying which level of influence the various deliverables may have in order to allow for a stronger vision. Now, I felt it was very important to engage key partners early and often in the development process, and this was supported not only by core public health and social policy principles, but the specific literature on competency-based practice. So after the literature review and environmental scan was completed, we began to engage with partners armed with this knowledge to seek understanding of the impact on current state and what these partners would like to see for a future model. Engagement styles varied, but we always aimed to include both nursing and allied health professionals and a variety of clinical leaders such as educators, professional practice leaders, and operational leaders. We were unable at this point to connect with patient or family partners or a reasonable cross-section of direct care clinicians. Ultimately, our initial engagement strategy aimed to have multiple opportunities to engage and to hit those key folks that we really needed buy-in from the most for the development of the initial model, with plans to engage more end users as the project progressed. The mix of engagement styles and inclusion of partners allowed us to use a narrative approach in the data analysis to tell the story of competency-based practice in interior health. We employed thematic coding to help pull themes to shape the framework and model priorities. This process was dynamic, and we responded to real-world priority shifts and organic engagement. From that initial engagement, we identified core deliverables that we felt was supported by the literature, the IH context, and our engagement as follows. It's an updated competency-based practice framework to describe the new model and support tool development, competency assessment tools to support self-assessment and identification of competence and competency, as well as an implementation plan and evaluation strategy, and a handful of adjunct deliverables, such as updating the health authority's intranet resources, establishing a governance process, and resource alignment with other related processes. The foundation of all those deliverables is the framework shown here. Its purpose was to establish that foundation of competency-based practice for nurses and allied health professionals. It allowed us to define and align understanding of competency-based practice, to differentiate what is needed to be a clinician compared to what is needed to complete a role or a task. It's that notion of competence versus competency. And then it allowed us to build the scaffolding needed to create a culture of continued professional development and enhance the overall utility of the existing tools. No small feat for a single document. Now, having gone into this practicum with rose-colored glasses on, it became increasingly clear as time progressed that we were not going to get through as much as we hoped. We were also faced with a key decision, which was whether we wanted to make incremental change or transformative change. With this in mind, I was able to hand over a final draft of the framework itself, but also some key recommendations for moving forward. Myself and the regional educator identified that engagement in this work is crucial and needs to be prioritized to ensure its success and to support the overall goal of ensuring high quality patient and family centered care. We also recommended that the clinical education team move forward in the direction that competency-based practice and clinical orientation are viewed as two dependent items rather than two independent entities. Seeing the two as deeply interconnected will allow for improved integration of competency-based practice principles into resources that direct care clinicians will actually use to support their role clarity, accelerate skill acquisition, and enhance clinician preparedness. This recommendation will require the team hits a bit of a pause to align with all the new and evolving information that came to light over the course of my practicum and align to create that seamless transition from onboarding to competency development, ultimately enhancing patient and family-centered care. This practicum was an incredible learning process, and I'm hopeful and excited to continue to develop and apply my new knowledge and skills to my future work. I also feel incredibly fortunate as a fellow Interior Health team member to be able to watch as the clinical education team takes this vision across the finish line. Thank you so much for your time today, and I look forward to your questions.